Hey, let's continue from last week. So we finished the adrenal insufficiency or Addison's disease. This time, let's do Cushing's. This is now a case of opposite problems. So if last week we had Addison's, which is a deficiency of the salt and sugar and sex hormones, this time we have an excess of salt, sugar, and sex hormones. There are two types of Cushing's. There's Cushing's syndrome, and then there's Cushing's disease. The manifestations are the same, the causes are different. So therefore, the treatment would be different. Again, the manifestations are the same because the patient has, in both types, the patient has excess salt hormone and sugar hormone. That means high cortisol and high aldosterone levels. Let's start with the manifestations first, and then we'll go to the causes. So if your cortisol is high, what happens to your blood sugar? Very high. And we mean constantly high. So what are consequences of high sugar all the time? Hyperglycemia, signs and symptoms, correct? And what will the body do with excess sugar? We turn it into what? Say you eat a lot of sugar, what will your body do with that sugar? Can you burn all that though? Store it as? Yeah, we can only store so much glycogen. What else will happen to the rest? Turns into fat. Okay, so will this patient gain weight? Okay, a lot or a little bit? A lot of weight. And the weight gain here is in such a short time that the body, especially the skin, cannot adjust rapidly. So the skin here is stretched in such a short period of time that it will cause striae and thinning of the skin, putting the patient at risk for skin tears and other injuries and bleeding as well. Now, let's continue with cortisol. So cortisol is a stress hormone. Besides the glucose being increased, what else does cortisol do? It's a stress hormone. So you're always under stress. So what will happen to your immunity? Okay, the patient here is at risk for infections. The obesity here is central type. You'll see a picture shortly. There's a buffalo hump, meaning there's a fatty deposit at the back of the neck, the base of the neck more like, makes the patient look like a buffalo. So there's abdominal obesity. The extremities remain relatively skinny. The legs, though, will have some edema because of the increase in blood volume as a consequence of high sugar and also the aldosterone. So high aldosterone will cause what with the water or fluid status of the patient? Water retention, right? So what happens to blood pressure? And what happens to sodium levels? Okay, increase, everything's high. Potassium, now, the potassium, theoretically speaking, is supposed to drop. However, the textbook doesn't mention hypokalemia as a problem, but theoretically, that's what's going to happen. Is that understood? Right. So here are the consequences. So as the patient has some develops the abdominal obesity, so that means it changes the patient's posture. So now the patient will have lordosis as a result. No, having to carry the excess weight in the abdomen. So that causes not only lordosis, but can also result in kyphosis. Plus, what happens to the calcium levels here of the patient? Because now you have more fat than muscle, so that will weaken the bone, right? Putting the patient at risk for osteoporosis And also it's a stress hormone. What happens to the gastric acids, intestinal acids? Increases. Okay, so this patient developed peptic ulcers. Okay, so a slew of health problems result from this condition. So we got the backache, compression fractures because of the osteoporosis. Sodium and water retention not only causes hypertension, but heart failure and the edema. They'll have moon phase, again, weight gain, slow healing, like I said, because of the immunosuppression. Who are at risk here? Between 20 and 40. So now we're looking at the sex hormone now. So the patient has excess sex hormone. So the patient will start growing hair in places where you shouldn't have hair. And imagine you're 20 years old and you look like this. Okay, so you look like a dude. Yeah, you have facial hair, you have excessive underarm as well as pubic and leg hair. So will that cause some depression? Okay, so affects patient physically and also emotionally. So here's a summary of your manifestations. There is again no difference between Cushing's syndrome and Cushing's disease as far as the manifestations go. They look the same. Only the treatment will vary slightly. So here you go. This is actually a woman, right? This is not a man. Here, see? This woman with Cushing syndrome, right? So let's go now. I won't test you on any questions on testing because the diagnostic testing is done, ordered by the physician. We really have no role in the testing. So they'll order blood tests and that's it. They have something called dexamethasone suppression test, but again, the nurse has no role here. Before we go to medical management, let's differentiate syndrome from disease. When we say Cushing syndrome, remember what we did with the Addison's patient last week? What was given to the patient with Addison's disease since they have low salt and sugar hormones? What was given to them? What was given to that patient? Every day for life. Hydrocortisone. Okay, they were given the hormone. Okay, so can we give them exactly the right amount of hormone, or can we give them not enough, or could we also give them too much? That's possible. When we end up giving them too much, this is the result. We call it Cushing syndrome. All right. Why syndrome? Because where did the hormone come from? Did it come from the patient's own body? The patient took it in the form of a pill or an injection or an IV infusion. That's how they got the hormone. We call it Cushing syndrome. So because it came from outside, the patient was taking it. Of course, there was a reason for taking it, correct? Besides Addison's disease patients, who else are taking hormones for life? Steroid hormones for life. Autoimmune patients. So those with Crohn's, arthritis, psoriasis, etc. Who else? What about organ transplant recipients? Yes, they have to take immunosuppressants. So there's an endless list, right? So there's so many people that can be forced to take steroids in order to survive due to a physical condition. So that can always put them at risk for Cushing syndrome. So because it's an exogenous source, what do you think is the management for Cushing syndrome? It's caused by an excess of the steroid hormone. So what do? We adjust the dose. Okay, so we meticulously adjust the dose so that the patient returns to an acceptable level body appearance, body image, as well as acceptable and normal levels of hormones. It's easier said than done, though. It's extremely difficult to arrive at a just enough hormones dose, because can we predict what will happen to your hormone needs from day to day? Very difficult, because the more stress, remember last week, when the more stress you have, we discussed the teaching, right? The more stress levels they have, what were they taught to do? Let's say some life events happening, so what were they instructed to tell their physician? Report it to the physician so that we can adjust the dose and we give them more, correct? So for that very reason, since we're titrating up, titrating down, it's very difficult to arrive at a just enough dose. So most of the time, they will end up with too much, causing Cushing syndrome. So that's how we handle Cushing syndrome. We adjust the dose. However, can we treat, or should we treat also the symptoms like the hypertension, the hyperglycemia? Yes, we can treat those as well. Can we prevent fractures? Yes, we can institute fall preventions. Okay, so we can manage the symptoms, but the treatment for Cushing syndrome basically is adjusting the hormone dosing. Okay. Now, when we say Cushing's disease, that is usually caused by a tumor. Now, we're talking about adrenal glands here, the adrenal cortex, the which is an endocrine gland. Therefore, it's controlled by the pituitary gland, correct? So there are two possible causes of Cushing's disease: either a pituitary tumor or a adrenal tumor. So they either have an adrenal tumor or a pituitary tumor. Because it's a tumor, what's the treatment? Surgical removal of the pituitary or adrenal tumors. So let's go to the adrenalectomy first, because it's the one mentioned here. So we have two adrenal glands. So we can either remove one or two adrenal glands, depending on which one has the tumor. If the patient loses one adrenal gland, do they develop Addison's disease? Do they develop adrenal insufficiency? One adrenal gland, they lost one. Will they permanently be in adrenal insufficiency? No. Only for a short time. It'll take maybe up to 2 years for the remaining adrenal gland to compensate for the loss of the other one. Okay, so we will give them hormone replacement for up to 2 years. Okay, only again up until the remaining adrenal gland can compensate for the loss of the other one. If, however, we lose both, let's say both adrenal glands grew the tumor, so we have to remove both, right? Now, what will the patient have after surgery? Adrenal insufficiency. Okay, so that now they have a deficiency in salt and sugar hormones. Are you following? Any question? All right, let's talk more about the surgery, because you have responsibilities here. You're the one sending the patient to surgery, and you're the one receiving them from surgery. Now, let's review. Before the surgery, what were the patient's salt and sugar hormone levels? Very high. When we send them to surgery, so when we remove an organ, we clamp the arteries and veins supplying that organ, correct? And then we resect the organ, remove it, and then sew them back up. What will happen if the patient's salt and sugar hormones were high all the time, and then did you slowly take it off or did you take it out suddenly? We took it out suddenly during surgery. So what happens to the level of the salt and sugar hormones in the blood? Did it drop slowly or did it drop abruptly? Abruptly dropping. So what's the difference between that and remember last week when we said patients taking hormones, steroid hormones, how should they stop taking the slow, gradually, right? We're supposed to taper because what will happen if they suddenly stop? Which will result in what condition? Life-threatening condition. Adrenal crisis or Addisonian crisis or acute adrenal insufficiency. Are they is that life-threatening? Yes, we said yes last week. What were the 3 problems the patient will have in adrenal crisis? Salt and sugar hormones are low. So, can they go into shock?
Yes.
Can they go into hypoglycemia?
Yes.
Can they go into hyperkalemia? And you agreed with me last week that all 3, each one is independently capable of killing the patient. So, since we have to take it out, so now what are we going to do? Are we going to just deal with adrenal crisis or can we prevent it? We will prevent it. Okay. So before surgery, the patient will be placed on steroids for about 1 to 2 weeks. What's the purpose of giving them steroids? When you give someone steroids exogenously, what will happen to their body's ability to produce the steroid? It's suppressed, right? Because by negative feedback, our body will say, oh, the steroids are high. I don't need to produce it anymore. So therefore, what happens to the vascularity and activity of the adrenal glands?
Stop.
It will lower. So therefore, when we cut it out, suddenly, will the hormone levels drop abruptly? Not anymore because we were giving the patient exogenous steroids. Make sense? Okay, so now the patient will receive steroids before surgery. Do we continue it during surgery? We better. What about after surgery?
Yes.
Yes. How long after surgery? Okay, very good question. Very good point. So if we took out both adrenal glands, how long will the steroid be? For life. If we took out one, up to 2 years. So this is what it says here. So if if the patient lost one adrenal gland, then there will be temporary replacement. Okay, for several months, up to 2 years, until again the remaining gland compensate for the loss of the other ones. Follow? All right. So that's your main responsibility before surgery. So we prepare them, and then of course you participate. This is a team effort, so you participate in educating the patient and making sure the patient will be safe after surgery. So we already discussed earlier, the patient will develop peptic ulcer. Some of them actually will develop type 2 diabetes because of the steroid therapy. Okay, let's go now to hypophysectomy, because we discussed the surgical removal of the adrenal glands if there's an adrenal tumor. What about if it's a pituitary tumor? So let's go to hyperpituitarism. It'll be a different section. Right here, pituitary tumors. Let's go to surgery, medical management. Right here. So this is page 1451. So it's, where did I find this? Under pituitary tumors, all right? But this is an option for Cushing's disease. Because what if it's not an adrenal tumor? What if it's a pituitary tumor causing the increased salt and sugar hormones? So hypophycectomy is the term we use when we're pertaining to pituitary gland removal. Now, how big is the pituitary gland? This mighty gland, the size of a pea. Okay. So which one is likely bigger? The gland or the tumor growing on it? The tumor. So is it possible a pea-sized gland with a tumor growing over it? Is it possible to excise the tumor and preserve the gland? Is that at all possible? Is that possible? I mean, the tumor is growing on it. How though? No, it's too small. It's now like attached, and how do you resect it? Yeah, it's impossible. So that you lose the pituitary gland, okay, when there's a tumor on it. So there's two approaches to remove the tumor and the gland. You can either crack the skull open. Okay, we'll open it, open the scalp, saw the skull open, and then somehow reach it through the um, big lobes, or you can go through the nose. Which one is easier? The nose, because the pituitary gland is located right behind between your eyes. Okay, right there. So it's easier to take it through the front. So what they'll do is hypophycectomy using a transsphenoidal approach. Transsphenoidal meaning they'll go through the sphenoid bone. They'll open the sphenoid bone and then put several instruments through there, through the nose. Of course, when we do this, are you awake? Definitely you will be on general anesthesia, correct? So they'll do this. Is this, since we went through the nose, does that mean it's not brain surgery? We went through the nose. It's still brain surgery. Okay, we just went through the nostrils, okay, via the sphenoidal approach. So after surgery, after all this trauma, and then they'll also have to go through, they'll put one instrument through the roof of your mouth, they'll put one incision there, and then so they can go up through the back of your throat, because they need to put other instruments there just to get to the pituitary gland. So there's a small incision at the roof of your mouth toward the back. So imagine the patient post-op. What will the patient look like? You had surgery through your nose. So what will the nostrils and the nose and your mouth look like? Swollen, right? Will there be a lot of bleeding? Okay, so can you breathe through your nose here? No. There will be a packing. So your nose will be packed with a lot of gauze in it. So you can't breathe through your nose, so you're gonna have to breathe through your mouth. Okay, so the patient needs to understand that. What precautions will be instituted? Can the patient sneeze? Should the patient sneeze? Should the patient cough? Should the patient bear down and pick up something? Should they sing Mariah Carey songs? Should they have sex? Should they cough and deep breathe? Okay, deep breathing fine, but no coughing. So therefore, what do all these activities I mentioned have in common? What is not allowed? So what are things, what activities cause increased intracranial pressure? When we, go ahead. When we, well, that's one example, but what else? What do they have in common? So let's say I'm singing Mariah Carey songs, or I'm giving birth to a big turd. I'm sneezing, I'm coughing, I'm bending down to pick up something. What did I do? Yeah, what caused the pressure in my head? What did I do? Imagine when I sing Mariah Carey, and then when I cough. When I sneeze. Shoo. When I bend down to pick up something. Or when I'm having sex. Right? A lot of what? What did I do? I took a deep breath and what did I do with it? I held it, correct? I took a deep breath and held it. Can you cough without doing that? No. Can you sing without doing that?
No,
Can you push a turd without doing that?
no.
No. Okay, so all these activities are prohibited. Next question is, how do you keep someone from sneezing? What do we give? Antihistamines. How do you prevent someone from coughing? Lidocaine. You can spray the throat with lidocaine. Suppress the cough reflex. Make sense? All right. So no sex, definitely. And what about the straining? I have to poop. Okay, give me stool softeners or laxatives. Okay, we don't want this patient straining. And of course, definitely no karaoke. All right. All right, so those are the brushing your teeth. Remember, there's a incision at the roof of the mouth. So what do I do? Can I brush my teeth? You know, I might, even if it's soft, even something soft, if I hit that, is there a toothbrush as soft as a Twizzler? No, even a Twizzler will injure my incision. So what do I do? Can I brush my teeth at all?
No.
No brushing your teeth for a few days. So what will I do instead? Okay, so I can do mouth rinses, non-alcohol mouth rinses. So we've got, what do we use? Yeah, Bactidol, right? Chlorhexidine. There's a chlorhexidine, and I can floss, right? So I can do that. All right, those are your pre and post-op for hypophycectomy. Okay. Any questions? Okay, let's finish up with Cushing's management. Let's go to the nursing care now. So we finish with medical management. You notice, unlike other conditions wherein there were medications, right? Yes, there are medications available, but the medications used here, these things mentioned here, these adrenal enzyme inhibitors, blah blah blah, are only for short-term or temporary use. They are not done long-term. So surgery remains the viable treatment for Cushing's disease. What was the treatment for Cushing's syndrome? Adjusting the steroid hormone doses. Okay. So here, if Cushing's syndrome is the result of administration of steroids, then we reduce or taper. Why doesn't this say stop it? Remember, the patient was taking steroids, what, for fun? It was for a reason, right? They had an indication why we placed them on steroids. It was either an organ transplant, an autoimmune disorder. So did the patient need the steroid? Or did they just decide, I want some? They needed it. So we can't stop it. All we can do is adjust the dosing. All right, let's go to the nursing care now. So remember, we have risks here for hypertension and heart failure. So monitor, can they go into pulmonary edema? All right. When these patients have osteoporosis already, so what will you institute? Okay, fall precautions, right? And what about when we pick them up? Remember, they have muscle wasting. These patients are weak. So when we pull them up in bed, how should we do it? Okay, slowly lift sheets, okay? Don't grab them by the arms. You can cause a fracture when you pull them by the arm or even cause skin tears. Is skincare important here? Yes, because the skin is very thin, especially around the abdomen. So take care that you don't cause any tears. Remember, they have immunosuppression. So how do you protect immunocompromised patients? Hand washing. Okay. What type of isolation will we institute? What do we call that when the patient is immunocompromised? Are they infectious? Who is infectious here? We are infectious, not the patient. Okay, the patient is immunocompromised. So what do you call that isolation? We did this last semester. Neutropenic. Okay, neutropenic, or other textbooks would call it protective isolation, or it can also be called reverse isolation. So instead of protecting us from the patient, we are protecting the patient from us. So I mentioned skin integrity. So practice good skincare. The body image, talk to the patient. This is not easy, right? Because can we change the appearance overnight? I mean, you can shave, but then they still have the neck, abdominal edema, the buffalo hump, the moon face. Okay, so it will take a while. So make sure you support the patient. And then what happens to the diet here? What diet will be given to the patient? Considering what you understand about Cushing's. Salt will be low, sugar will be low, calorie will be low, protein will be high because they are losing protein. Okay. And yeah, encourage verbalization of feelings. That's all we can do with coping, right? Provide support. We talked about Addisonian crisis last week for Addison's disease and or adrenal insufficiency. Here, the patient, once we do surgery, either adrenalectomy or hypophysiectomy, what will the patient develop as a result? Addison's. Okay, so this is for for Cushing's disease patients. So Cushing's disease patients undergo surgery, correct? After the surgery, what did they develop? If it's bilateral adrenalectomy or hypophysiectomy, what do they develop now? Addisonian disease, Addison's disease. So what is the treatment for Addison's disease? What? Hormone replacement for life. So what can the Cushing's disease patient who underwent surgery, who developed Addison's disease, who is now put on steroids for life, potentially develop? Cushing's what? Syndrome.
Because they get into
Correct. So the patient will tell you, let me make this clear. Wait a minute. I have Cushing's disease, and now you're gonna treat me based on the plan you're telling me that I will go from Cushing's disease to potentially Cushing's syndrome, right? So the patient will say, I don't believe this, right? So it's important that the patients understand the plan. So they're not gonna have unrealistic expectation. Oh, finally I'm gonna turn sexy again. Okay. So no, you could potentially go back to this scenario, right? So important that they understand. So that's the problem with cortical and mineralocorticoid deficiency, okay, or excess. Any questions on the two topics? And here's your discharge teaching. All right.